I am Dr. Sonia Sasidharan, Assistant Professor, Department of General Pathology. Today I will be discussing the topic iron deficiency anemia. Anemia is defined as reduction in total circulating red cell mass below normal limits. There are many causes for anemia, but the most common cause is iron deficiency. Iron deficiency is the most common nutritional deficiency disorder. Before going to the topic proper, I would like to discuss about the normal iron metabolism in our body. Iron is absorbed from duodenum and proximal jejunum, and during iron absorption, our body adopts a mechanism called mucosal block mechanism. That is, iron absorption is enhanced in our body when iron stores are low, while it is limited or it is decreased when we have adequate iron stored in our body. The ferrous iron is absorbed by the intestinal cells with the help of divalent metal transporter. Inside the gut cells, iron is stored either as ferritin or further transported to plasma by two vehicle proteins, ferroportin and hephaestin. In plasma, ferrous iron is converted to ferric iron, which combines with apotransferrin to form transferrin. Iron is transported by transferrin to the developing erythroid cells to synthesized hemoglobin. In our body, iron is distributed as hemoglobin, myoglobin, in heme and non-heme enzymes, transferrin bound iron, and storage forms of iron like ferritin and hemosiderin. Now coming to the topic proper, that is iron deficiency anemia, we will first see what are the causes for iron deficiency anemia. The first cause is increased blood loss from our body, which can be due to many causes like uterine disorders like excessive menstruation in reproductive years, repeated miscarriages, at onset of menarche and postmenopausal uterine bleeding. Gastrointestinal causes like peptic ulcer, hemorrhoids, hookworm infestation, cancer of stomach and large bowel, esophageal varices, hiatus hernia, renal tract causes like hematuria, hemoglobinuria, other causes like repeated epistaxis and hemoptysis can lead to iron deficiency. Increased requirements like spurts of growth in infancy, childhood and adolescence, prematurity, pregnancy and lactation. If in these cases the demand for iron in our body is increased, and if we don't meet that need, it can lead to iron deficiency in our body. Next is inadequate dietary intake of iron, as in poor economic status, anorexia like in pregnancy, elderly individuals due to poor dentition, apathy and financial constraints. And sometimes iron absorption is affected when there is a decreased absorption of iron from our body, like in partial or total gastrectomy, eclorhydria, or intestinal malabsorption such as in celiac disease. Now coming to the clinical features of iron deficiency anemia, the person will show all the features of anemia like fatigue, weakness, dyspnea, pallor, palpitation. Sometimes in elderly patients or in severe cases of iron deficiency anemia, the patient can show angina and congestive heart failure, pica. Also, there will be associated epithelial tissue changes like koilonychia, atrophic glossitis, or Plummer-Vinson syndrome. Development of anemia in iron deficiency can progress in 3 stages. First is storage iron depletion. Here, this is the first stage of iron deficiency. Here, our storage iron is depleted, but there will be sufficient iron to be supplied to the erythropoietic cells or for erythropoiesis. So, there won't be any anemia clinically. In the iron deficient, erythropoiesis can come next. Here the erythroid iron supply is reduced, but there won't be any anemia without development of anemia. And third stage is the frank iron deficiency anemia, where the RBCs will become microcytic and hypochromic due to decreased hemoglobin synthesis due to the deficiency of anemia of iron. Now coming to the lab findings in iron deficiency anemia. First we will see what are the changes occurring in the peripheral blood. First of all, the hemoglobin level will be lower than normal because the synthesis of hemoglobin needs iron, and during the deficiency of iron, or if there is deficiency of iron, the hemoglobin synthesis will be compromised and there will be fall in hemoglobin concentration in our blood. The RBCs will show changes in size and shape, that is, there will be anisopoikilocytosis. We will be able to see ovalocytes, elliptocytes, target cells and microcytes in the peripheral blood, and the RBCs will be microcytic and hypochromic. The reticulocyte count may vary. It may be normal, reduced or slightly increased if the patient is taking iron therapy or if he is having active hemorrhage or something. If we come to the absolute value or blood indices, MCV, MCH and MCHC will be reduced. Coming to the bone marrow findings, the bone marrow cellularity will be decreased with the increased in erythroid precursors, or there will be increased erythroid hyperplasia. The erythropoiesis will show many micronormoblasts, and the marrow iron will be deficient or absent. Biochemical changes include there will be decreased in serum iron levels, total iron binding capacity will be increased, serum ferritin level will be low, red cell protoporphyrin levels will be low, and serum transferrin receptor protein levels will be raised. Here we can see the changes in red cell morphology as well as in normoblast in iron deficiency anemia. The red cells will be normocytic, normochromic in a normal person, while it become microcytic and hypochromic in iron deficiency anemia. In normal erythropoiesis, we will be able to see normoblast, while in iron deficiency anemia, we will be able to see many micronormoblasts in the bone marrow. Now coming to the treatment, the first thing we have to do during the correction of iron deficiency anemia is to correct the underlying cause, whatever it is. If it is due to increased blood loss, or if it is due to any hookworm infestation, or if it is due to any dietary deficiency, we have to correct that. And for the correction of iron deficiency, we can adopt oral therapy by giving ferrous sulfate, ferrous fumarate. And if the patient is not tolerating the oral therapy, like in pregnancy, we can move on to parenteral iron therapy by giving ferric gluconate or iron sucrose. So that's all about iron deficiency anemia. Thank you for listening.